Okay, good. So thank you, Laura, for that introduction, and thank you for invitation to come back and speak at SMI. It's really a privilege. So as Laura said, I was an SMI student in 2005, so after my first year of medical school, and it was really a formative experience for me. Learned a lot, grew a lot, really enjoyed it. So I actually came back 2 years later in 2007 as a student director. I really enjoyed it then. And, there was so much to take away. I mean, it's great because you, in addition to learning what it means to sort of live out your faith in medicine and interact with people who are ahead of you in medicine and ahead of you in the faith, I think for me, what was one of the most important takeaways was just the importance of community and the deep community we had at SMI, and how important that was as a person in medicine, particularly. In community, we get to see a little bit of Christ in others. But I think more importantly for me, I think what it did for me was just show me my own sin and self-centeredness, and caused me to turn to Jesus and depend on him more fully. And I think realizing that showed me how important it was to really hold on to community as I continued on through training. We're going to talk about a lot of science and medicine behind COVID-19, but if I leave you with one sort of lesson about your training in medicine, it would be to just be intentional about connecting with other believers, either at your local church or with other believers in medicine, wherever you're training, because it's easy for medicine to become a master for people and be very demanding, and so you have to be very intentional about holding on to community and prioritizing what's important. So, so just a little bit more background on me. I was born and raised in Philadelphia. I grew up in an Indian church called the Marthoma Church, sort of similar to the Episcopal Church in the U.S., and came to faith around the age of 12. I did most of my training in Philadelphia. I was an undergrad and medical student at Penn, and then did my residency over at University of Pittsburgh in internal medicine. Came back, I was a hospitalist for 2 years at Penn, and then decided I wanted to do infectious diseases. So I went over to Temple for 2 years and trained, and then came back to Penn, and I've been working as an infectious disease specialist for the past 5 years and have really enjoyed it. So I'm happy, at the end or afterwards to take any questions about infectious diseases or infection control or about COVID-19 or about anything else. So with that, let me go ahead and jump in. Let's see. All right. So I thought I could start with a verse here. So this is from Romans 8, and as I've been thinking about the COVID-19 pandemic over the past few months, this is a verse that's come to mind. For the creation was subjected to futility, not willingly, but because of him who subjected it, in hope that the creation itself will be set free from its bondage to corruption and obtain the freedom of the glory of the children of God. For we know that the whole creation has been groaning together in the pains of childbirth until now. So this is important to me because it sort of helps me to interpret the times that we're living in. What we're seeing in the pandemic is really the effects of the fall. Nature isn't what it was created to be. It's alienated from us. It's in bondage to corruption. As believers, we know, though, that this isn't the last word, that God is preparing out of this mess a glory that we couldn't even imagine right now. And we get to play a part in that as believers and as people in medicine in restoring that creation to the way it's supposed to be. I think the whole analogy of childbirth and the pains of childbirth is interesting, because if you think about the pain and groaning that occurs in delivery, it's not a meaningless pain, right? There's a purpose to it. There's an outcome that you're looking forward to, and that is the birth of a new life. And I think as we look around at what's happening in the world around us and see the pain and the suffering, I think we can interpret that in the same way, in that God can take this and out of this really make something beautiful that we may not be able to see right now, but that he is weaving in into his story and in his providence. So and keep that in mind as we continue through this pandemic and as we work to help people through it. All right, so with that, here is an outline for what I want to cover today. I know it's not easy to be interactive over the virtual setting, but I do want to try to make it as interactive as possible, so please feel free to ask questions. I'm fairly certain we're going to have time at the end for questions as well, so you can also save it till then as well. So first, just a little bit of background on the virus. We'll talk about the epidemiology, which is sort of a fancy way of saying, how the disease is distributed across the population, how the disease presents in patients, how it's transmitted, and a little bit about how to prevent acquisition of the virus. So first, some background. So the virus that causes COVID-19 is called SARS-CoV-2, which stands for Severe Acute Respiratory Syndrome Coronavirus 2. It's 2 because there was a SARS-CoV-1 back in 2003, so almost 17 years ago now. There are about 7 strains of human coronavirus that have caused infections in humans, 4 that circulate seasonally, and 3 that have caused novel outbreaks this century, including SARS-CoV-1 and MERS, which is Middle Eastern Respiratory Syndrome, that came on the scene in 2012 and has sort of smoldered along since then. The disease caused by SARS-CoV-2 is called COVID-19, or Coronavirus Disease 2019. That was the name that WHO gave it in February, prior to which we just called it the 2019 novel coronavirus. We initially thought that the virus arose out of a live animal market in Wuhan, China. Certainly the first cases that were identified were around that time from that live animal market. You see some pictures of that market here. When you have all of these animals together in one setting, it's sort of a great breeding ground for viruses to exchange genetic material, for new viruses to arise, and for them to make that jump from animals to humans and then to transmit between humans. I think more recent data suggests that the virus was probably circulating in Wuhan even before this live animal market, but certainly the animal market played a role in spreading the virus. So this is just a look at the current status of COVID-19 across the world. This is a sort of a helpful tool that Johns Hopkins has put out online, and you can Google it, and it has lots of different ways that you can play around with the graphics. I pulled this data from about a week and a half ago, and I took a look at it again yesterday. So the total number of confirmed cases has actually increased to about 11.4 million at this point, with about 530,000 deaths worldwide. The U.S. has the most confirmed cases at about 2.9 million now, with about 130,000 deaths. And you see there the list of countries in order of number of cases. Brazil has the second most cases, and they've had an outbreak over the past month or so, and followed by Russia, India, United Kingdom. China, where the first cases started, has about 85,000 cases. It's important to keep in mind that these numbers are based on the number of confirmed cases, so it does depend on the amount of testing that's happening in each of these areas, as well as the population density, as well as what types of sort of mitigation strategies are in place in these different countries. So moving closer to home, this is the current status in the US, and again, these are numbers from June 26th. You can see up in the left-hand corner the sort of heat map showing the number of reported cases in different parts of the country. Most cases reported in Northeast. New York, of course, was the epicenter for a long time. And more recently, we've seen a lot of cases in Texas, Florida. California was certainly hard hit as well. And then on the bottom graph, you see the number of new cases each day since the beginning of the pandemic in mid-March. And what you'll see is we sort of peaked in early April and then sort of trended down slightly since then. And then within the past couple of weeks, there's been a rapid rise in cases, which we'll talk a little bit more about. The New York Times has some helpful graphics and charts to show what's happening across the U.S. And I think, as we all know, the incidence is now increasing in many states across the U.S., mostly in the South and Southwest. Of particular note is in Arizona, Florida, Texas, Carolinas, where the number of cases has been increasing rapidly. So moving even closer to home, this is the incidence of cases in Philadelphia. So similar to the rest of the country, we had our peak in early April, and then the number of cases has slowly trended down since then. And in the past, I'd say two to 3 weeks, I'd say they sort of plateaued at a lower level. This is the same sort of curve that we have in our hospital within the Penn Medicine system. Where we had several hundred cases in early April, and currently I'd say across the downtown hospitals we probably have about 30 to 40 cases in total across all those hospitals. So certainly it's declined and plateaued now, and hopefully stays there or continues to decrease. This is a map of Philadelphia showing the number of cases per 10,000 residents on the left, and then the percent of people testing positive on the right. You can see the sort of hardest hit areas are North Philly, Northeast, and Southwest Philly. I put an arrow where I believe Esperanza is located, and does appear to be one of the more harder hit areas in the city. All right, so when you think about a virus or really any pathogen spreading in the population, I think its impact can be determined by two key factors. One is how infectious is the virus, so how easily does it transmit from person to person, and when someone acquires, and the other factor is when someone acquires it, what is the effect on that person? So what is the mortality from the virus? This was another chart put together by New York Times several months ago, and has actually proven accurate over the past few months as we've gathered more data. On the x-axis here, you see the infectivity of the virus. We call that the R value, and it's basically a measure of the average number of people infected by each sick person. So that's on the x-axis. So that's how infectious the virus is, and then on the y-axis you have the fatality rate, right? So what percent of people who acquire the virus will pass away from the virus. The pink box is sort of the area where the coronavirus was expected to be. This was, again, early in the pandemic, it's probably taken in February or January even maybe. I put a star where I think coronavirus is based on the data that we have so far. So in terms of infectiousness, it is more infectious than the flu, than the common cold, more infectious than MERS and Ebola. So the R value is thought to be between 2 and 3. So the average infected person probably infects about 2 to 3 people. In truth, what's actually happening is there appears to be a small number of people that are infecting a large proportion of patients, and then many people who aren't infecting anyone. But if you average that over the course of the population, on average, each infected person is probably transmitting the virus to 2 to 3 other people. In terms of mortality, if you look at cases overall, it's probably about 0.5%. So that's, or maybe even less than that. And that's including all of the asymptomatic as well as the symptomatic cases as well. So certainly more deadly than the flu or the common cold, or chickenpox or measles. So chickenpox and measles are certainly much more infectious, but this is probably a little more deadly, at least than chickenpox. But nowhere near as deadly as, for example, Ebola or smallpox or MERS or even SARS-CoV-1. So what about the impact on individual patients so far? So this is data from the Chinese experience, and I think it's mostly held true within the US experience as well. And that is that about 80% of people have mild disease. That is, they don't require hospitalization. They can manage the disease as an outpatient. About 15% require hospitalization. 5% require an ICU admission. And the Chinese experience was about 1.4% mortality. As I mentioned, I think the mortality in the US is likely lower, probably about 0.5% overall. The CDC has been trying to track or trying to determine what percent of the population has been infected at this point. So on the right-hand side, that graph that you see is the percentage of the population that has tested positive for antibodies to SARS-CoV-2. And what they did is they basically took blood samples for patients who were giving blood for various reasons unrelated to COVID, and they took those blood samples and tested them for antibodies. And keep in mind, these are blood samples taken between March 23rd and May 3rd, so this is almost 2 months ago now. And not surprisingly, what you see is that in places like New York or Connecticut, about 5 to 7% of the population appear to have been infected, at least as of May 3rd. It's probably a higher number at this point, whereas places like South Florida, Missouri, Utah had lower rates, closer to about 2%. But again, these numbers are probably higher now than they were 2 months ago. All right, so what are the risk factors for having more severe disease? Probably the most important risk factor is age. The older you are, the higher the risk there is for morbidity and mortality, up to about 15% mortality for those who are 80 or older. And certainly comorbidities play a role as well. Those with heart disease, diabetes, high blood pressure, lung disease, kidney disease, cancer, certainly obesity. We've seen a fair number of patients in the hospital who have no other medical problems apart from obesity, but still require hospitalization for COVID, smoking, liver disease, and immunocompromising conditions. So what happens after you're exposed? How does the virus actually present? So with all pathogens, there's an incubation period, and that means the period between when someone's exposed to the virus till when they actually develop symptoms, right? So this data was taken from about 190 cases in China, and they looked at the time between exposure and the time when patients develop symptoms, and they found that the median incubation period was about 5 days. So it takes about 5 days between when you're exposed and when you actually develop symptoms. And so this is about the same as SARS-CoV-1. It's about 2.5 times longer than the flu. So the flu typically presents within about 2 days after exposure. But of course, there's a range here, right? So some patients will develop symptoms within 2 days, and some patients can develop symptoms up to about 14 days out, right? Which is why we have this sort of quarantine period of 14 days that's required after someone is exposed to the virus. About 98% of people will have symptoms within about 11.5 days after exposure. So what are the symptoms that patients with COVID-19 develop? So there's a wide range, and I think we all know this at this point. You can be completely asymptomatic from the infection. I think our best estimates now are maybe about a quarter of people who pick up the infection are asymptomatic. But then, of course, there is a significant minority that develops severe disease, including respiratory failure and death from the virus. The most common symptoms we see are fever, cough, shortness of breath. Those are the most prominent, and then along with that, we can see muscle aches, headache, new loss of taste or smell, which is one of the more sort of specific symptoms from the virus, a sore throat, congestion or runny nose, nausea, vomiting, diarrhea. I think if you find someone who's got the GI symptoms plus the new loss of taste or smell, that's sort of a very specific constellation of findings that has sort of a high diagnostic value for the virus. And then there are some other sort of rare manifestations. There's rarely some dermatologic manifestations, some skin findings. Some of you may have heard of COVID toes, where you get this sort of red discoloration of the toes. This often happens late in the disease. Unclear why this happens, but there may actually be direct invasion of the virus into the blood vessels in those toes, or it may be related to clotting. So we know that patients with COVID are at much higher risk for developing clots. And so when they're hospitalized, they're actually put on significant blood thinners to prevent the formation of clots, and stay on those blood thinners for about a month after they leave the hospital. And then there are a variety of other skin manifestations that have been seen seen with COVID as well. So what about those patients that are hospitalized? So actually most patients who are hospitalized end up being hospitalized in the second week of the illness. Patients often develop symptoms within their first week, sort of peter along for a little bit, and then they get worse in the second week, leading to hospital admission. ARDS, which stands for acute respiratory distress syndrome. It's sort of an inflammatory response in the lungs that leads to the need for mechanical ventilation and ICU admission. So it's important to that patients are aware of that things could get worse in the second week of the illness. All right, so how is the virus transmitted from one person to another? So the best data we have suggests that it's primarily through respiratory droplets. So droplets are sort of these small mixtures of saliva, mucus, and other things from your respiratory tract, including virus, that come out when you breathe, when people exhale, or when you cough, or when you sneeze. And when they get out into the environment, other people can inhale that, or it can land in the environment on surfaces around you or on the floor. People can touch those surfaces, and then it can get from their hands onto their face, and you can get infected that way. So the primary mechanism appears to be inhalation of respiratory droplets, and probably to a lesser extent, contact transmission. A helpful sort of mnemonic or phrase that people use to understand transmission, or the factors that drive transmission, are time, space, people, and place, right? So time, if you're around an infected person, the longer your exposure period around that infected person, the more likely you are to pick up the virus. Space is important. So the closer you are to an infected person, the more likely you are to pick it up. The further you're away, the less likely you are. 6 feet is sort of a good rule of thumb, but I'd say the further away, the lower the risk. People, certainly situations where there are a higher density of people, where there are crowds of people, where there are more infected people. Some people tend to be more infectious than the others. That's an important factor, as well as the setting you're in when you are exposed. So outdoors are certainly safer than indoors, and particularly indoor settings where there's poor air circulation or poor ventilation, where there's no sunlight. Those are higher risk settings. So the highest risk settings, right, are crowds, where there's a high person density, where you're indoors. We see many cases based on household exposures. That's probably the highest risk situation I can think of in the community, where you're living in the same household as someone who's infected, as well as prolonged exposures to someone who's infected. And as I think I mentioned, it's clear that there is transmission from asymptomatic patients, as well as pre-symptomatic patients, so patients who are in that incubation period, those first few days after they're exposed, they can transmit the virus, as well as transmission from symptomatic patients as well. There were a couple of interesting sort of case studies of how the virus spreads that I thought it might be good to share. So this is from an article published a couple months ago that described an outbreak at a restaurant in Guangzhou, China. There are 3 families here seated at tables A, B, and C. The family seated at table A had just traveled from Wuhan the day before they were in this restaurant. So the day before they traveled from Wuhan, everyone at the table was asymptomatic, but patient A1 was actually infected at the time they were there, and he went on to develop symptoms after this dinner, but he was infected at the time he was there in the restaurant. You can see there's an air conditioner on the right-hand side of the restaurant, and so there's airflow going from right to left here, which means that the people downstream from that airflow are at higher risk. And there's poor ventilation in the restaurant, so there were no windows. And over the course of about an hour, about 9 people were infected, including 4 people in the patient's own family, 3 people downstream at table B, and 2 people at table C. And I think this is interesting to think about, because I think it shows not only the importance of ventilation, of pre-symptomatic transmission, of distance. So not every, there are certainly patients here who are infected who are further than 6 feet out from patient A1, but because of the poor ventilation and the time involved, about an hour, they were still infected. Of course, the spacing was important here as well. So this is another case study that some of you may have heard about, related to a choir practice, where a large percentage of the attendees were infected. So this was in Skagit County, Washington. There were 61 people who attended a choir practice on March 10th. One of those people were infected at the time of the choir practice, and they were actually symptomatic. There were several opportunities for transmission here, both droplet and contact. So, as you can imagine, everyone was seated very close together. They were eating, so sharing snacks. They were singing. When you're singing, there's a higher number of droplets and aerosols because there's louder vocalization. Even more with coughing and sneezing. And so lots of opportunities for transmission. And by the end of this choir practice, about 53 out of the 61 people who were there ended up being infected, which is a very large proportion. This is what we call sort of a super spreader event. 3 of these people were hospitalized and 2 died. Important to keep in mind, the average age of the people here was about 69 years old. So this was certainly an older population. There was certainly a significant amount of time involved, a 2.5-hour choir practice with loud singing involved. So this was I'd say a high-risk event. All right, one of the questions that I get commonly is, how long are patients infectious after they pick up the virus? And our knowledge of this has been sort of evolving over the course of the pandemic. The CDC has criteria around which we can discontinue isolation for patients who are infected. And that criteria has 2 components to it. One is that the patient is at least 10 days from symptom onset. And 2 is that they've had at least 3 days of being without a fever and having their symptoms improved. And this is based on data both from transmissions as well as from culture data. So they've tried to culture the virus from patients who are infected, and they haven't been able to culture the virus beyond about 9 days from when symptoms. If you're able to culture the virus, that tells us that there's live virus there and that can actually be transmitted between patients. And they've also looked at transmission pairs. So pairs of people where one person was infected and they transmitted to another patient. And what they found was that your infectiousness peaked actually right before you develop symptoms. So in the time before symptom onset, about 44% of the transmission events occurred. So close to half of transmission occurred before the patient ever developed symptoms, and the other half developed after symptoms. And so your infectiousness sort of wanes significantly over the first week. That's what you can see on the left-hand side here, that on the x-axis, you see the days after symptom onset. Day 0 is where the line is. And then the y-axis is sort of the percentage of transmission events that you're seeing during that time frame. Some of you may have also heard about reports from the Korean CDC a couple months ago where they had cleared patients from isolation using an even more conservative strategy where they actually required 2 negative tests from patients and they were cleared from isolation. And then about 180 or so of those patients tested positive again about a month later. And it was unclear whether this was reinfection or reactivation or what it was. And after further study and after looking at about 800 of their close contacts with those patients, none of them actually transmitted the infection. So those patients actually weren't infectious. So I think the takeaways from that are that it's clear that you're infectious for a short period after you develop symptoms. There's probably some level of immunity, at least in the short term. That's probably within a couple months, at least a couple months, though we don't know that for sure. And you are very unlikely to get reinfected in that time frame. And it's important to note that your test can actually stay positive for up to 6 to 8 weeks after you develop symptoms. So a positive test by itself does not necessarily mean that a patient is infectious, but it does indicate that they've either had the infection or they currently do. All right, let me just talk for a minute about exposures. So how do you define an exposure? So the CDC's definition for an exposure is being in close contact with a patient with COVID-19 who is infectious. So close contact, per the CDC's definition, means being within 6 feet for about 15 minutes or more, or being in direct contact with secretions. And that means, for example, someone coughs on you or someone sneezes on you. So no matter how long of a time you're there, if that happens, that would be considered close contact. The infectious period, as I mentioned, is 2 days before symptoms start until the patient meets criteria for discontinuing isolation. So if you're in close contact with someone during their infectious period, that would be considered an exposure. And if that happens, what's recommended is a quarantine for 14 days from the last exposure. And I say last exposure because, you know, there are some people who are being continuously exposed, for example, household contacts. So if you're living with someone who is infected with COVID-19, you're sort of being continuously exposed. And until when that infected patient comes out of isolation, you are actually required to stay in isolation for 14 days after that. So actually the household contact is often in isolation for longer than actually the infected patient is in isolation. During that quarantine period, you're self-monitoring for symptoms, checking your temperature twice a day to determine if infection is actually developing. In healthcare settings, we have a little bit more nuanced exposure definition that involves high, medium, and low risk exposures based on the level of PPE used at the time of the exposure. So certainly if you're in full PPE, and we'll talk about what that is, that would not be considered exposure. There are also certain high-risk settings in healthcare settings, things that we call aerosol-generating procedures. For example, an intubation or a bronchoscopy, where there's more, it's more likely that aerosols are generated into the environment. Those are high-risk situations where you need a higher level of PPE with an N95 mask. And then there are sort of medium and low-risk exposures based on the level of PPE that's being used at the time the exposure occurs. All right, so what about testing? So unfortunately, you know, throughout much of the pandemic, our testing capacity has been constrained. It's certainly much better than it was 3 or 4 months ago, but probably not as good as we'd like it to be quite yet. And so what that means is that we've had to prioritize testing for the sort of most highest yield situations. You know, currently, testing is recommended for all symptomatic patients, with giving priority for those who are hospitalized, those who are immunosuppressed, certainly close contacts of confirmed cases, healthcare workers, residents of congregate living facilities. So I didn't talk about this, but you know, COVID-19 has really ravaged nursing homes across the United States, as well as other congregate living facilities, things like prisons and homeless shelters. It's been high rates of infections in those settings, and high mortality as well. And then outpatients with comorbidities as well should be prioritized. We do test asymptomatic patients in select situations, so prior to certain high-risk procedures like surgeries, or if you've had close contact to a confirmed case, testing is offered in some situations there. It's a little bit unclear at what point testing should be done, but in general, it's recommended about 5 to 7 days after the exposure. It's important to recognize, though, that if you have a negative test in that setting, that doesn't take away your need for quarantine. You can have false negative test results. And as we noted, there can be up to a 14-day incubation period. So if you have a negative test of 5 to 7 days after an exposure, you'd still need to quarantine for the full 14 days, for the full 14-day period. And then occasionally we'll test asymptomatic patients in congregate living facilities to try to identify infections early if we think there's an outbreak occurring. Okay, so finally, prevention. So how do we prevent acquisition of COVID-19? So PPE is important, right? So personal protective equipment. This is the PPE that's being worn in healthcare settings when taking care of COVID-19 patients. There's sort of the preferred PPE, which involves an N95 mask, eye protection, where we've learned more and more over the course of the pandemic about how important eye protection is. Those are exposed mucous membranes, and virus can get into the body through the eyes, so it is important to protect the eyes. And we typically do that with a face shield or with goggles. And then there's, of course, contact transmission, so a gown and gloves is also important. At Penn, for much of the pandemic, we've just been using a face mask for routine care or surgical mask, and then an N95 for more high-risk situations like aerosol generating procedures. There's also sort of a very detailed method of donning and doffing PPE that we go through when entering and exiting rooms of COVID patients in order to prevent ourselves from getting contaminated. All right, what about in the community? There's been a lot of discussion about universal masking over the course of the pandemic, and it's interesting how that's evolved. Towards the beginning of the pandemic, not many authorities were recommending universal masking, and as we learned more about the virus and guidance evolved, and now universal masking is recommended in many communities across the U.S. And the thinking here is not so much that it's serving to protect the people who are wearing the mask. It does offer some protection in that setting, but it's more important because it offers what we call source control. And what that means is it's actually blocking droplets from the person who's wearing the mask, which means it's preventing droplets from asymptomatic or symptomatic patients from getting out into the environment and from infecting other people around them. And so I'm wearing a mask to protect the people around me, and other people are wearing a mask to protect the people around them, right? So that's the main benefit, and there is a secondary benefit from protecting the wearer as well. Both surgical and cloth masks are effective in this regard. Surgical masks might be a little bit more effective. They're made from a special material called polypropylene, which is more effective in sort of capturing the virus in the mask. They're also a little bit more breathable, which means we're touching them less and adjusting them on our face less, and we tend to keep them on a little bit more. So they tend to be a little bit more effective in that regard. N95s are really only indicated for healthcare settings, and I don't think there's really a good indication to wear them in the community. We can talk a little bit more about that in the next slide. And you should know that in Philadelphia, within the past couple of weeks, there's been a new mandate for masking. It's required in all indoor public places, as well as outdoors when you are near others who are not part of your household. So a couple more thoughts on masking. I mentioned, it's probably not an indication to wear an N95 when you're in the community. The mask I have on the top left-hand corner is a specific type of N95 that has an exhalation valve. It's a type of mask that's used in construction settings to prevent construction workers from inhaling dust and droplets. But it's particularly not helpful in this pandemic because, as you can see, there's an exhalation valve that allows the person who's wearing it to breathe out, and it allows that air to exit the mask. And so if the main benefit of universal masking is that it's preventing infected people from transmitting droplets, a mask with an exhalation valve is sort of defeating that purpose. So I would strongly advise against that. And then I've seen some people wearing the mask on the bottom left-hand corner. It's an elastomeric mask. It also has exhalation valves, not helpful for the same reasons. A couple of points to keep in mind when you're wearing a mask. It's important that it's covering both your nose and your mouth because there are droplets from both of those areas. So we want to prevent exhalation of droplets from either of those mucous membranes. It's easy to, occasionally we need to adjust our mask, and that's, it's reasonable, but it's important to try not to wear it, sort of below your nose or on your neck or sort of on your arm. And to use hand hygiene when you're taking on or taking off your mask. All right, and then thinking more broadly about public health interventions. Of course, there's been a lot of debate about this, and I think there's certainly a good debate to be had about the economic impact of these interventions. But I think what's important to note is that they are effective. So this is a study that was done on 2 neighboring counties, one county in Iowa and one county in Illinois. And the county in, Illinois had actually issued a stay-at-home order on March 22nd, while Iowa did not. And what you'll see is that after that stay-at-home order was put in place, the number of cases in Iowa increased more rapidly than in Illinois, or in that specific county in Illinois. After about a month, the Iowa County had about 300 more cases than the county in Illinois. And I think we're actually seeing this play out in real time, right? So over the past couple of weeks, we've seen that cases were falling nicely over the past couple months. Within the past 2 to 3 weeks across the South and Southwest and some of the areas that have reopened, we've seen a significant rise in cases. Interestingly, more in young people. I can tell you, even from the patients that we've admitted to the hospital over the past week, they tend to be younger patients, and that may be related to the fact that younger people are getting out more into the community as things are reopening. And so, I think there is certainly a risk there, and we'll have to see how this plays out as things reopen more, or as things get scaled back potentially. All right, and then social distancing. I mentioned this briefly earlier, that 6 foot is a good rule of thumb for brief exposures, and increased distances are more protective. In the picture there, you see what happens when someone sneezes, and you see the sort of the respiratory droplets that are there, extending about up to 7 to 8 meters there. So I would say if you're standing in a line at the supermarket, 6 foot is probably good. But if you're going to be somewhere for an hour or 2 hours, probably longer distances are more important. The graphic on the right is taken from the Lancet and just shows the effect of different interventions, including physical distancing, face masks, as well as eye protection. All right, and then finally, hand hygiene and environmental disinfection. Environmental transmission likely happens, but it's probably not as important as droplet transmission. Hand hygiene is important, and the frequency of hand hygiene matters. The more you do it across the day, the more helpful it is. You can use alcohol-based hand rubs. They're very effective. You want at least 60% ethanol or 70% isopropanol in those hand rubs. Soap and water is also effective. You want to do it for at least 20 seconds, and you particularly want to use soap and water if your hands are visibly soiled, or before eating and after using a restroom. The disinfectants that we have are highly effective in killing coronavirus. So if you wipe down a surface, you can feel very confident that you've killed all of the coronavirus there. And the EPA actually has a list of registered disinfectants for SARS-CoV-2. Coronavirus does survive on surfaces, but not very well, not as well as some other bacteria that we know about, like MRSA or C. diff or things like that. It survives on hard, non-porous surfaces like stainless steels longer than it does on soft, porous surfaces like cloth surfaces. All right, so to summarize, COVID-19 poses a significant risk for the population, with the highest risk for those who are elderly and those with comorbid illness. And it has significant secondary impacts on the rest of the population. I didn't talk a lot about the secondary impacts, but in the midst of this pandemic, we've had to put a lot of other care on hold. We've had to empty a lot of the hospitals. We've had to put a lot of outpatient appointments on hold. People with cancer have had to delay their chemotherapy. And so it's had a lot of secondary impacts on people who don't have COVID-19 because of the impacts it's had on overwhelming the hospital system and the healthcare system. Presentations range from being completely asymptomatic to severe pneumonia. Transmissions occurring primarily through respiratory droplets via both pre-symptomatic and asymptomatic patients, as well as symptomatic patients. There are effective measures for prevention, including universal masking, social distancing, hand hygiene, environmental disinfection. PPE is also important, and standard PPE for COVID-19 includes a surgical mask and/or N95, eye protection, gloves, and a gown. And I think we can expect continued transmission until an effective vaccine is available. I didn't talk much about vaccines, but there are many, many vaccines in the works, a couple that are appearing quite promising. And the hope is that we'd have something available potentially even before the end of the year. So I started off with a verse, and I want to leave you with 2 verses here. One is from Psalm 91. He will cover you with his pinions, and under his wings you will find refuge. His faithfulness is a shield and buckler. You will not fear the terror of the night, nor the arrow that flies by day, nor the pestilence that stalks in darkness. And that's what this is, right? This is a pestilence. And finally, from the same chapter that I pulled from at the beginning of the talk, Romans 8, And we know that for those who love God, all things work together for good for those who are called according to his purpose. And I think that's a truth that we can hold on to in the midst of this pandemic. All right, so I will stop there, and I'll be happy to take any questions. I think we have a couple minutes left. Those are my 3-year-old and my 10-month-old. So happy to take any questions.
Go ahead, Holly.
I was just wondering, do we actually know, if we know that that transmission or infection from one person to another may happen 2 days or so before the start of symptoms in the infected person? Do they have any idea how long infection that person is infectious for after symptoms?
Yeah, so it looks like it's about, at the most, 10 days. It drops off significantly over the first week of your developing symptoms, but then about 10 days, you can come out of isolation, assuming your symptoms are also improving at that point and you're afebrile. And for most patients, that's the case. Yeah.
Yeah, I think Esperanza is using 10 days total or 3 days totally asymptomatic, whichever's longer.
Yeah. Yeah, that makes sense.
So it can be longer if you're symptomatic for the full 10 days, and your symptoms don't drop off until day 11. Then you're in isolation for 14 days.
Yeah.
And then I noticed the China cases really haven't bumped up much since their original reporting back in January, February.
Yeah.
Do we trust that number? Are they really that good at controlling containment? They might be now. They might be really scared. So they might be that good at control and containment and contact tracing. But
it's so hard to know. It's hard to know how much is being reported, how much is being tested. I think certainly with public health measures, there's probably more enforcement there in regards to keeping people socially distant and keeping people masked. But how much that's contributing to the actual numbers, I don't know. Yeah, but it's a good question. I think it's true for a lot of the other countries where we're seeing a low number of cases. I don't know how much of that is just due to the fact that we're not testing, in a lot of those situations. It's hard to sort of tease those things out.
And if nobody has another question, I do know Esperanza has a SARS-1 story, and I can tell the Esperanza SARS-1 story if you want. But
I did have a question.
Yeah, go ahead.
Jerry, could you just comment as a ministry that wants to try to help support people in healthcare, what impact has this had on people that are practicing healthcare? How's this been for you? And how can we support people that are dealing with this? Yeah,
I think a couple things. So I think it's been a very scary time for a lot of people in the hospital setting. A lot of healthcare workers have been affected and infected as a result of exposures. At the beginning of the pandemic, there were a fair number of patients who were coming to hospitals who either had false negative tests or we weren't expecting coronavirus, and there were significant exposures. Many who were quarantined. There were staffing shortages in a lot of places, and so it's a scary thing to consider that you could potentially be infected, potentially infect your family as well. And so a lot of healthcare staff have had to quarantine on their own or just decide to live elsewhere in the midst of the pandemic. And so that's been difficult. I think our situation's a little bit better now, at least in Philadelphia. PPE was an issue early on, but I think that's improved somewhat at this point. I think it's also been difficult for families at home with the closure of childcare centers and difficulty with childcare, and especially two-doctor families, I think can be very difficult, or two people in medicine or in healthcare setting. That's certainly been difficult. So So I think it's presented certainly some unique challenges there. I think I've seen, for example, at Penn, they put out a lot of resources to help people with sort of mental health issues. There's been a lot of exacerbation of underlying mental health issues as a result of the anxiety around the pandemic within healthcare workers as well. So I think a number of different issues, both I think spiritual and physical issues coming out as a result of what's happened.
And how can we pray for you specifically, Jerry? Anything in particular?
Yeah, so I'm involved with the infection control effort, specifically at the facility that I have responsibility for, but then we collaborate across Penn Medicine. I don't think this is going to end anytime soon. We've had to rethink how we do a lot of things in healthcare, and we've had to prepare for a potential surge in the future. So wisdom in making those decisions and in working with people in very stressful settings would be helpful. And then I think closer to home, just with my wife is also a family practice physician, and we've got 2 little children, so it's been hard for us for childcare and dealing with that over the course of the pandemic. So that would be, prayers for that would be helpful.
Any more questions, and or would anybody like to pray for Jerry? Both.
I'll pray for Jerry. Dear Heavenly Father, I thank you so much for Jerry and his daily work. Lord, I thank you for his family and the work that he also does there, Lord. And we know that all of his work is given up unto you as a joy of service unto you. But we just pray that you can allow him to have perseverance and his family to have strength through this time, to be supportive of one another, and most of all, Lord, to feel your presence by his side each day as he goes about his work, and his wife's as well, that knowing at all times that you love them and care for them. And we thank you for all these things, and what a blessing he has been to us today, that just take a little time out from his schedule and give us this information. In your name we pray. Amen.
Amen.
Thank you. My email's up there, so please feel free to contact me with any questions or if I can help with anything.
So we wanted to actually say thank you to you, Jerry, for helping, especially Laura and us, try to think through a lot of the issues, whether to even have SMI, how to do it safely. You and Laura have communicated a ton, and this probably wouldn't have happened without you and without your guidance. So we just really want to say thank you. And I don't mean to jump in and take words out of Laura's mouth, but I didn't want this to end before us saying a big thank you to you. So you guys, we were not going to do SMI, and then Jerry was like, well, maybe you can. So we want to thank him so much. So
Appreciate that. It's a privilege for me. Thank you.
We really appreciate it.
Thanks.
Amen. We're buddies now. We're like this.
Yeah, no, I appreciate it. It's a joy for me to be able to help out. So thank you.